And we move on now. May I invite Dr. Ravindhran C, please.
So, good morning all. First of all, I thank Bibin and team for giving me this opportunity. Regards from Trichy Surgical Society. My topic, which was given by Bibin, was Beyond the Lump, the Strategic Approach in Neck Nodes. I remember my first day in clinics when I went to clinics and Professor Varma sir and I think Dilip sir is also there, was talking to us saying that was the first sentence when we had a neck lump, that any lateral neck lump you think about nodes and any midline neck lump you think about thyroid. I rather feel that we should extend it a bit, saying that any solid asymmetric neck lump laterally should be considered metastatic, otherwise proved. And we have found that, and the literature also says almost 80% of them are found to be squamous cell carcinoma. We all come across this problem, and as aptly pointed out, the approach is really beyond the lump. You need to think differently, you need to think in a strategic, systematic way based on the guidelines to reach into a correct diagnosis. Nothing compromises on your clinical examination, focused clinical evaluations and investigations with a sound knowledge of your anatomical localization of the particular swelling, which will give you an idea and some idea regarding which all pathologies can occur in the particular location, which will help into get into the diagnostic reach. If you're an adult neck mass, I just wanted to put in this algorithm. When you find an adult lymph nodular mass, it can be due to a myriad of conditions, right from infective, chronic inflammatory, immunological conditions like Castleman's and Kikuchi. What we are concentrated at the moment is malignancy with an identifiable primary or an non-identifiable unknown primary. Approach is almost identical, but if you can get into a diagnosis by your basic investigation into any one of them, treat it straight on, that is the easiest way. That is either imaging, an FNAC or clinical immunological test. Getting into a diagnosis, the lump and or the conditions can be managed directly. And if you can locate a primary, you're lucky enough in 60 to 70%, you can straight away get on with the treatment problem. But the problem comes when by your preliminary investigation doesn't reveal any primary. Then whether we to investigate, there are a lot of theory regarding clinically unknown primaries, which can be either hidden lesions, can be due to slow growth rate. Whatever it is, as a clinician, your idea is to find out what is a probable primary. Why we need to do a primary is to know about the primaries, and how to know about it is just by the basic clinical examination. Basic idea about the whole anatomy and the drainage area with related to the region, and focus your attention to that. I'm not going to the individual drainage areas because it's beyond, I think, for the august audience like this, I don't have to go into each and every aspect. But the point to the postgraduate is, look about the drainage areas first. There is nothing which can replace your redo clinical examination and redo history before you contemplate any investigation in a clinically unknown primary. You should be focused in your examination based on the nodal sites, and you know very well that various nodal regions do have got a definitive pattern of drainage. We have got skip patterns from level 2 to level 4 in tongue and all, head and neck, upper head and neck malignancies, but definitely there is a definite systematic pattern of involvement. So when you find a primary nodal lesion in particular site, first look for a proper clinical examination. Your clinical examination can be extended by ideally in an oncological setup by doing an office endoscopy, which may not be a direct laryngoscopy, video laryngoscopy that is available. You can even do an indirect laryngoscope or a mirror examination of the nasopharynx, which we most often skip these days and send it to ENT. I think as a general surgeons, we should be looking at this area to identify a possible primary. So why we really need a primary? Because there are a lot of studies that you can empirically start treating clinically unknown primary. But knowing the primary gives an adequate treatment output, because you can definitely have a clearance and then subject to the further treatment. So definitely investigations are mandatory to identify the primary before you contemplate the further treatment. Coming to the next thing, we have an unknown primary. Between what to do, tissue diagnosis or imaging. If it is an unknown primary by your initial clinical evaluation and imaging, I would rather say a tissue diagnosis will be a valuable clue to take you further. Right? An FNAC can very well get you into at least 1/3 of the diagnosis by ruling out certain condition, picking up certain condition, and guiding you for further evaluation. Right. So you can actually diagnose serious conditions like papillary carcinoma, squamous cell carcinoma, and adenocarcinoma, and then further take you for further investigation in the histopathological lines. And the distribution of malignancies, you know that very well, that it's predominantly squamous cell and followed by the other types. How will you subtype them? And the role of IHC has come in a big way, because knowledge about exact type of tumor will help you to locate the primary in a better way. Because if you have got an upper tumor with a squamous cell, you need to look above, and if you have got a squamous cell carcinoma which is 4 and 5, look down below the clavicle. That is what we need to do. Right. Now, is FNAC ultrasound guided core biopsy or surgical excision biopsy is the ideal one? Ideal one, according to standard literature, is ultrasound guided core biopsy, but I'm sure that many of us sitting here will be a little wary about putting a core needle biopsy on location of the certain needles in particular location. So, but literature says core needle biopsy is ideal, and I'm sure that standard centers with expertise and are doing that for core needle biopsy, because it can give you a core of tissue which can be used for IHC for primary IHC markers, which can subtype it into two different classes. And if it is adenocarcinoma, you can further subtype. I'm not going to the details of it again, but by using algorithmic approach, you will be able to get into which organ you need to particularly look for. Right. And the role of molecular testing has come in a big way as well. And there are standard assays with 92 genes, which can even detect up to 56 subtypes of tumor. And this is also something like a mammoprint for breast. It is coming in a big way in occult malignancies. Again, the HPV and HPV testing, which will help you to identify where exactly the tumor. And there are practical implications that you can guide your biopsy, guide your treatment, and guide your radiation if you can find if the person's with EBV or HPV positive. Cross-sectional imaging, definitely between CT and MRI, I will go for CT first, and between CT and PET CT, definitely PET CT has an advantage, because it can definitely identify the primary than the CT or MRI. MRI doesn't have an undue advantage according to literature as well as from my clinical experience, but basically PET CT has got definitely a positive advantage. Last but not the least is when you can't find a primary, look at the areas where you need to look for, which is guided by your PET CT. And the question with the pan endoscopy is whether to go for blind biopsies. The role of blind biopsies at the moment is controversial, and it doesn't have any role to go for blind biopsies from nasopharynx and oropharynx which has been recommended previously. And the role of tonsillectomy, which is again in literature, has got a debatable role in identifying the primary, right? But basically, almost all basic investigation can fetch you the diagnosis. So, finding out the primary is an exciting, it is our motto, and you need to follow a algorithmic approach, and maybe the pattern which you follow may be differing in basic institutions and oncological institutions, where your clinical examination followed by first biopsy and then by imaging, or imaging followed by biopsy. If not, go for endoscopy and then tonsillectomy plus or minus. Because in the end, when you have ruled out and found out a primary, you can direct your treatment accordingly. And if you have not found out a primary, you can subject your treatment in that way. So in this very short, quick talk, because it's a huge topic, I thought this is the best summary I can give. That is the approach in case of a neck node with relation specifically to the clinically unknown primary. Thank you so much.
Just a quick remark from the chair, please.
Thank you. It was an excellent presentation. What about the role of tonsillectomy?
It has been advised by, that is, if you can't find a primary, you can do epislateral tonsillectomy in certain selected cases. But I've been talking to Madhu, I've been talking to Sharath, I was talking to Sahir, both of them are with me. And according to the practical purpose, at the moment, the role is still controversial. I think the experts are there again to comment on it, sir. My personal experience is there is not much role at the moment, but literature says it can pick up around 20% of hidden malignancy, especially the lingual tonsillectomy.
Tonsillar crypts, sometimes carcinoma in situ,
Yes, sir.
will be there.
Thank you, sir. Can we move on, please? Thank you, sir.
Thank you so much.
Thank you, Dr. Ravindhran.